Sudden cardiac arrest, or SCA, claims one life every 90 seconds, and only 15% of those lives receive appropriate therapy. Identifying patients who are at risk of SCA and augmenting their care pathway is challenging for healthcare institutions across the country. However, efforts to automate patient identification and care management is advancing through the use of artificial intelligence. My name is Justin Hibbs, and as your host today, I'd like to first thank you for joining us. We have a fascinating agenda featuring experts in education, cardiology, and technology to explore how innovative programs are enabling smarter cardiac screening, which can optimize program quality, the efficiency of physician workflow, and the ability to better identify patients at risk for sudden cardiac arrest. In fact, aggregated cardiac data can help healthcare organizations monitor, analyze, and streamline processes to deliver life-saving patient and healthcare outcomes. And our speakers today are driving approaches forward that come up with options to manage this area, which can address health equity in underserved populations. We will explore all of these topics during our Vizient program today, which is an extension of our service line approach where we combine expertise, data, and technology to drive end-to-end category management. Let's start by looking at our speaker lineup. Dr. Sanjay Gupta, MD, MBA, Associate Professor of Medicine, and board-certified electrophysiologist at St. Luke's Mid-America Heart Institute, will share the latest research on undertreatment of patients at risk of SCA, current barriers to care, and today's standard of care treatments. Logan, brigman, CEO of Mpirik, will share real-world application of AI for the cardiac service line and how it augments care for patients at risk for cardiac disease. And Dr. Oscar Julian Booker, MD, MSHQS, MBA, a practicing cardiologist, clinical director, and associate professor at UAB, will highlight his team's experience successfully using AI to detect at-risk patients, improve quality of patient care, and alert caregivers in real time about potential undertreatment. Thank you again for your participation. You will have the opportunity to interact by asking questions using the chat feature on your screen. Now I'd like to turn it over to Dr. Gupta to explore the impact of sudden cardiac arrest.
Thank you. I'm Sanjay Gupta from St. Luke's Mid-America Heart Institute, and I'm excited to be starting off our discussion on leveraging artificial intelligence to enhance cardiac patient care. So sudden cardiac arrest is an unexpected death or arrest that typically occurs outside the hospital. It is a major international health problem, accounting for approximately 15 to 20% of all deaths. In the United States alone, 500,000 patients will die every year from sudden cardiac arrest. Now, although resuscitation rates are generally improving throughout the world, the majority of individuals who experience a sudden cardiac arrest will not survive. So therefore, prevention and early detection for risk factors for developing sudden cardiac arrest are key to treating this epidemic. So throughout all causes of sudden cardiac death, the most common cause is coronary heart disease, particularly in Western countries where it accounts for about 75% of all causes of sudden cardiac death. There's some variability internationally, and rates can be as low as 50 to 60% in countries like Japan, and even within countries, the discrepancies between genders and ethnicities. And this is due to several factors, including substrates in the myocardium, including fibrosis and hypertrophy, various triggers, including ischemia and inflammation, and several predisposing factors such as genetics, gender, and other factors such as sleep apnea, smoking, diabetes, etc. Closely followed after coronary heart disease, the next most common cause are cardiomyopathies, of which these are typically, we're talking about the non-ischemic cardiomyopathies, such as examples include hypertrophic cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy. Again, there are some variabilities in different countries. And then followed after that are the inherited arrhythmia syndromes, such as long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, and other syndromes such as that. And then finally, valvular heart disease, and then other causes round out our list of sudden cardiac arrest etiologies. Now, if you look at age at onset, there is some variability over the course of someone's lifetime in terms of various risk factors. So in young patients, typically they're more commonly going to have channelopathy, such as long QT syndrome, catecholaminergic polymorphic tachycardia, or genetic cardiomyopathy, such as hypertrophic cardiomyopathy, or arrhythmogenic hypertrophic cardiomyopathy. Now, in early adulthood, sudden cardiac arrest is typically due to idiopathic cardiomyopathy, such as non-ischemic dilated cardiomyopathy, Brugada, or channelopathy, such as Brugada syndrome or early repolarization syndrome. And then in late adulthood, cardiac arrest is most commonly coronary heart disease or valvular heart disease, as we saw. Now, if you look internationally, there are some real differences between incidences of out-of-hospital cardiac arrest in terms of both attended and treatment by EMS providers. And if you look to the rates are lower in Asia and highest North America. There's a lot of differences, reasons for that. They're not only in etiologies there, but also in EMS protocols, autopsy rate, even public reporting standards vary between the countries. So there may be other reasons to explain for this variability. But if you look within each country, what the variability in terms of cardiac causes of cardiac arrest is highest in North America and then lowest in Asia. So among women, interestingly, women generally have a lower incidence of sudden cardiac death and sudden cardiac arrest than men, even accounting for other predisposing factors such as coronary heart disease, MI, and heart failure. Now, there's lots of interesting reasons for that, thought to be smaller body habitus actually improves success of defibrillation. There's also thought that estrogen may have some beneficial effect on the effect of defibrillation and on post-resuscitation hemodynamics, which is interesting. Now, women who do experience sudden cardiac arrest are on average older, more likely to present with pulseless electrical activity and experience their arrest at home as compared to men. And then of any gender, if you look at, there's racial differences as well too, and Black as opposed to white Americans have been documenting higher rates of out-of-hospital cardiac arrest, and unfortunately are also less likely to receive pre-hospital resuscitation efforts. Now, the good news is we are achieving some reduction in rates of sudden cardiac arrest, and you can see just by getting people to quit smoking that your rates of sudden cardiac death do decrease years after quitting smoking. But unfortunately, the reduction in cardiac arrest in the coronary heart disease population has not been as steep as for other causes of coronary heart disease death. There's also a growing proportion of sudden cardiac death that is not due to coronary heart disease. So the mainstay of therapy and prevention and treatment of sudden cardiac arrest is implantable cardiac defibrillator therapy, which are devices inserted into the heart that can terminate lethal cardiac arrhythmias and have demonstrated to improve survival in high-risk populations. And although sudden cardiac arrest is a very heterogeneous condition, having an EF less than 35% still remains the single best factor for risk stratifying patients for prophylactic ICD implantation. And despite the fact that there are 500,000 cardiac arrests that occur each year, we're implanting about 75,000 devices annually in the U.S., suggesting there's a large under-treatment of sudden cardiac arrest, and there's lots of reasons for that. And so one of the reasons could be, if you look at for the treatment gap is typically look at this care pathway to see a cardiac specialist. So when a patient visits a physician for typically the primary care physician for symptoms or a checkup, they may not order an echo. They may contribute symptoms that would have been hallmarks or potentially predisposing factors for cardiac arrest to just getting old, and they're not getting these issues flagged. So there's a breakdown in the care pathway. Even when they order an echo, they may still fail to refer those patients to a specialist. The PCPs may not be familiar with treatment guidelines. The guidelines are always changing. There's sometimes a perceived risk of surgery by non-surgeons, or the patient just doesn't follow up. They make the referral, patient doesn't go, and eventually, hopefully, the patient gets it. But there's lots of opportunities for the process to break down, even when people are trying, to follow the rules. All right, so what do we know and what do we not know about causes of sudden cardiac arrest? So we know that about 45% of patients with sudden cardiac arrest have known coronary heart disease, and about 55% have no known cause. So delving into that population, you can see that about 34% are what we'd expect, people who have heart disease at autopsy, and we have 35%, but were just never diagnosed. And obviously, this represents a failure to detect or for people to recognize symptoms that may have been important. But there are people who have heart disease and EF less more than 35% as well. And again, this shows that the EF less than 35% is not a perfect prediction. There are people who are dying with a normal EF with heart disease. And finally, there's a group of people who have no heart disease autopsy and also have normal EFs as well too. And this represents a little bit of a mystery for us, and we still understand all the risk factors. Some of these may have channelopathies that were undiagnosed, but we still don't know about those. So as Donna Rumsfeld famously said, there's known unknowns and unknown unknowns. So, the known unknowns represent people who have known heart disease but are not diagnosed. And we really need to do a better job at detecting those people and figure out, how we can get early diagnosis and treatment for those patients. But there are also these unknown unknowns where patients we don't understand why they had cardiac arrest, but that they did experience it. We need better research to understand that. And so really, if we can, but in the present day, even if we can just focus our efforts with artificial intelligence to decrease sudden cardiac arrest patients who have known heart disease and the less than 5% who are not getting plugged into the system, that alone would dramatically decrease rates of sudden cardiac arrest that we see every year. So looking at risk stratification for sudden cardiac arrest, again, the most important and common cause is people who've survived sudden cardiac arrest. So we call aborted sudden cardiac arrest for VTAC or VFib. And this falls in the category of what's termed as secondary prevention of cardiac arrest. And then the remainder of these causes are patients who have not experienced cardiac arrest yet, but remain at risk for developing it. And so these are patients who have an EF less 35%, 40 days after an MI, patients with EF less 35% despite optimal medical therapy for more than 90 days. And there's people who also have a channelopathy with high-risk features. And finally, patients have a non-ischemic cardiomyopathy also with high-risk features. So if you look at the different types of implantable cardioverter therapy that are out there, the most commonly thought of is the transvenous implantable defibrillator, which with leads inserted into the ventricles that can detect arrhythmia and deliver therapy directly there too. In the last several years, we have developed the emergence of the subcutaneous defibrillators, which now there are two different types available, which can not require leads to be inserted actually into the heart, but just under the skin, and they can also deliver life-saving therapy. And for patients who don't qualify for these yet or are still in an evaluation period, there is a wearable defibrillator. Now there's two different types of these as well too that patients may use during that evaluation period, or if they have an infection or other condition that would preclude implantation of a defibrillator at the time of diagnosis. So there are several unmet needs in sudden cardiac arrest therapy. We need better research into novel markers of sudden cardiac arrest to improve the accuracy of risk stratification, particularly in those patients who have no heart disease at autopsy and have less than 35%. We need to understand why those people are dying. We do need automated continuous monitoring of sudden cardiac arrest with integration with both genomic and environmental data to get really a complete understanding of all the risk factors that are leading to sudden cardiac arrest. And we need to close gaps in care between patients who are known to be at risk for sudden cardiac arrest and who receive ICD therapy. And these are all things that we believe artificial intelligence can help answer and help close that gap. And that's why we're excited about the promise of AI. Now, if you look at AI, really, we're just talking today about how closing gaps in sudden cardiac arrest, but there's so much more that we can accomplish that is really beneath the surface. We can look at using AI to advise on anticoagulation for AFib just based on bleeding risk alone. We can guide medical therapy based on the ASCVD risk calculator and power algorithms based on the best evidence, latest evidence to direct guideline-directed medical therapy. We can use the Framingham risk scores to then power algorithms to then guide lipid treatment. We can determine optimal duration of dual antiplatelet therapy following an MI or percutaneous coronary intervention. We can use the GRACE score to evaluate patients who are at risk of dying following acute coronary syndrome and guide the intervention of treatment post-intervention. We can use algorithms for heart failure readmission risk scores to guide therapy and risk stratification and follow-up following the hospitalization. So really, AI can be used to guide therapy throughout all of cardiology, and we're really just scratching the surface of what's out there and what's possible.
My name is Logan Brigman, CEO at Mpirik, and I'm here to talk about the application of artificial intelligence in a real-world scenario and how we've applied it. In general, AI in healthcare is poised for exceptional growth. One report indicates a growth of at least 38% year over year. And when we look at understanding the goal of AI in healthcare, it is different than many other industries where we're not necessarily trying to replace humans. We are trying to augment these clinicians with the help of artificial intelligence, which is why I love this quote: AI will not replace clinicians, but clinicians who use AI will replace clinicians that don't. And AI plays a major role in healthcare to provide scalability. When we look at the volume, velocity, and variety of data, it will always continue to increase. So scalability will be vitally necessary given a combination of clinician burnout, an aging population, and a massive increase in healthcare data, as you can see here, where in 2015, you've got 153 exabytes of data, and then now as of 2020, the estimates were about 2,300 exabytes. And it's kind of hard to understand what that volume of data means. So to put it in perspective, some studies will claim that all the words that have ever been spoken by humans would equal only 5 exabytes. So as you can understand, we'll need AI systems to be able to take some of the load off of these clinicians. And we want to program the brain of them, such as Drs. Gupta and Booker here today, to help scale patient care and patient surveillance. So one such application is the one I'm here to talk about today, which is cardiac intelligence. And our mission is to end undertreatment of cardiac disease with a software as a service solution that takes in a stream of data from the healthcare organization to assess patients that may need more appropriate and timely treatment. So to give a little bit of background about our capabilities, we've screened over a million patients. We've got about 17 health systems with 90 plus hospitals there. And we continue to grow on, as Dr. Booker will highlight, the cardiac screenings that we do and the different quality improvement metrics that we're able to provide a health system. So with all the data we've been referencing, the majority of it will be seen as unstructured free text. A field of AI called natural language processing has been growing to make sense of this free text and provide labels to this data for use in algorithms. And as you heard from Dr. Gupta as well about sudden cardiac arrest, there are many factors outside of hemodynamics that attribute to these risk factors that should be identified for understanding appropriate patient care. And these variables are typically saved as free text. So we get a constant stream of EHR data sent over HL7, and this can be echocardiogram reports, clinician notes, ECG reports, clinic visits. And what we're going to be doing is a pre-processing step where we take all of that free text, run it through our natural language processing engine to do those patient labels so that we can run it through our rules engine. This rule engine in step 3 is really here to answer 2 questions. 1, does the patient have any sort of cardiac disease? And if they do, does it look like they have an appropriate treatment plan for that disease? And we assess these with a number of inclusion-exclusion criteria about, does the patient have dementia? Do they have a future clinic visit scheduled with the appropriate specialty? And so if we've found that the patient has disease and no appropriate treatment plan, we'll want to send an appropriate message to the care team to ensure that that patient gets the appropriate follow-up. The path to success will involve definitely more than 4 steps, but what we've found are these 4 major ones. 1 would be that natural language processing. There is so much of the data that is locked in free text that is needed to improve accuracy of these screens. And what we found is that over 50% of the diseases or the patients we've screened for disease required free text assessment with our natural language processing engine in order to identify them appropriately. You'll need to be able to integrate seamlessly with any EMR, and that can be done with the likes of HL7. You'll also want to be able to provide value across the service line so that the efforts involved from the IT group to set up this sort of data stream will be worth it. And then finally, you'll need to reduce the degradation of the data set. Over time, people will provide research on how to look at diseases differently. The nomenclature of disease severity and risk factors will be ever changing. So we have machine learning algorithms that will assess our NLP dictionary and constantly be looking to improve or maintain that accuracy. And that leads us to talking about gaining confidence. So after you have a data stream and AI platform, you'll need to gain confidence from the physicians. So we provide rigorous validation through research and clinician collaboration. One such report is this Annals of Thoracic Surgery publication we produced this year, showing an assessment of 77,000 echoes with a high accuracy of 98.6% when screening moderate and severe aortic stenosis patients. So in practice, you'll need to define inclusion-exclusion criteria to find these patients. And as Dr. Gupta illustrated earlier, there are a lot of different data sources providing the data necessary for this evaluation. Doing this effectively means running a screening protocol as the data is coming in and then assessing the patients at that point. So what that would look like then is you've got a clinic visit coming in one day. You've got another day the clinician notes about maybe that visit with different data sets. And there's a lot of data incorporated in each of these data stream events, but we would only necessarily need to pull certain aspects of it. And so you need to have this care pathway management system to constantly take it in and assess the most recent data for the patient. So it's not seen as a one-time protocol screen, it's a continuous event. And to highlight that continuous assessment that's required, when we looked at about 200,000 of our patients with at least 2 echocardiograms and showing a sign of a disease severity increase within 1 year, over 50% of them did not have an appropriate follow-up scheduled within 6 months. And so this leads us to the next aspect where Dr. Gupta had mentioned, maybe many of these patients don't necessarily need follow-up this very second, but we should put them under surveillance so that they come in 6 months or a year for that new ECG or echocardiogram or assessment, because a lot of this is managing this cardiac chronic condition that some patients have. In summary, what we're going to be seeing is a vast increase of patient data. That's the volume, velocity, and variety of data coming in, and building artificial intelligence systems to actually augment these clinicians that are experiencing burnout from not only COVID, but in general, this increase in an aging population as well. And we're here to try to close the loop from data to action, and not just producing lists of patients, but actually getting them the appropriate care that they need. And also on the side, then gaining confidence by producing collaborative reports with our partner hospitals. Thank you so much. And I'm happy to pass off to Dr. Booker from UAB Medicine to talk about the application in a real world hospital setting.
Good afternoon, everyone. My name is Julian Booker. I'm a cardiologist. I'm also the director of cardiovascular imaging at UAB. And we're going to discuss our experience with artificial intelligence at UAB. So our agenda for today, we're going to discuss the logistics of AI at UAB, the results of using AI for patients with structural heart disease, and then our plans for expansion to address patients at risk of sudden cardiac arrest and beyond. So before we get started, I'd like to present to you what our guiding principle, our guiding vision for artificial intelligence, what our plans are at UAB. And we believe that every patient with high risk cardiovascular conditions should receive timely and appropriate care. And if we keep that vision in mind, I think it'll allow us to better address why we decided to leverage AI. We wanted to solve that problem, and we felt that AI was ultimately our best solution. It's not the only solution, though. There is the traditional personnel-based, human resources-based solution. But there are some challenges with that. And those include overall staffing shortages, turnover issues, cost, and patient or employee satisfaction, because this can be fairly repetitive work. And as you can imagine, as we continue to suffer through COVID, these issues have only been exacerbated. The benefits potentially are quick deployment. But again, in the midst of COVID, that is open for debate. Alternatively, we could build our own solution. Do you have the available expertise? Some places like UAB do, most places don't. It's a long development time, and this can be incredibly expensive. The benefits, once it's built, you own it. The third solution was, should we move with a vendor that has an already prepared AI solution? The challenge is, how do we integrate that vendor into our system? The implementation challenges, making certain that there are no issues with security and compliance. And then how do you justify with ROI? The benefits, you have dedicated resources, technical expertise, fast development. It potentially is scalable to many diseases. And then we have reduced human and IT resources over the long term. But now, how do we evaluate clinical AI solutions? Traditionally, the main focus is on compliance and security, and how does that AI solution mesh and fit with the AI, with the compliance and security guardrails set by your institution? Has that AI been successful in the past? Can the AI be integrated into your EHR system? What offerings do they have? Is it going to be too expensive? Can you justify your return on investment? And does your team believe in what you're doing and the system that you're bringing in? But perhaps we should look beyond that to also consider, is the system, is the solution customizable? And is there a willingness to collaborate with the vendor? So for us, we started with a very specific focus on some very specific disease states. We started with severe aortic stenosis, severe mitral regurgitation, and we started with aortic root, ascending aortic dilatation, and aneurysm. But in the next phases, we're looking to move forward with sudden cardiac arrest, guideline-directed medical therapy, and that's a very broad one, reaching from heart failure to hypertension to diabetes to pretty much any cardiovascular-related disease state that the AI can support us with. Heart failure, including with preserved ejection fraction and reduced ejection fraction. So how does it work? For us, cardiac intelligence sees our echo reports, and then it crawls our clinic and procedure schedule. It collates all that and identifies patients that it deems to have one of the high-risk conditions that we discussed before. And if you meet a certain threshold, we will then send a notification in the EHR to the ordering provider to let them know that this patient has met certain criteria, which may suggest further follow-up and further intervention could be beneficial. So what have we found to be the case after our implementation? For me, this is probably one of the most important take-homes. 20% of the clinicians surveyed felt that the notification impacted their decision to refer. So I receive a notification, and perhaps I wasn't considering referral to an additional specialist, but these notifications have driven me to pursue what the guidelines have suggested to be the appropriate care. Beyond that, 56% of all patients with severe aortic stenosis and severe mitral regurgitation notifications resulted in a follow-up appointment. We've had 105 interventions following notifications. 66% or 2/3 of clinicians surveyed would like to continue to receive these notifications. Also, equally important, we've had significant improvements in our overall echo quality. And we've had the overall time from index echo, identification of disease to follow-up events has been reduced. So specifically for aortic stenosis, when compared to before notifications, 8% of patients with a non-cardiologist as the ordering provider now receive follow-up. Now, if we use patients that had a clinician notification would compare it against follow-up for using a propensity score-based match patients prior to go live, we've had an overall 8% increase in follow-up and a 16% increase in clinic visits. Now, if we look at patients with mitral regurgitation, compared to before the notifications, we had a 9% increase in follow-up echoes and time to follow-up of an astounding 41 days. A 15% increase in overall follow-up. That's echoes, clinic visits, and interventions. And then specifically for primary mitral regurgitation, we've had a 15% increase in follow-up, a 17% increase in intervention, and a 12% increase in follow-up echo. Interestingly, some of our QI work has been the most impactful, and we've seen an improvement in our own abilities and skill sets for not only the sonographer, but also for the providers. We're more sensitive to the detection of the disease. We're able to track volumes real time. We can identify discrepant reports. And when I say discrepant reports, I mean internal discrepancies where the data, the numbers don't necessarily match with the stated report, but also look for discrepancies between a previous report to make certain that there is an expected consistency between a previous report and the current report. And perhaps most importantly, it serves as motivation for continuous process improvement. If we look at this very specific case for how we address and how we assess aortic stenosis, we can see that before alerting and after alerting, we've had a significant increase or a significant increase in the average gradients across the aortic valve, as well as a diminution in the measured aortic valve area. And some of this is driven, actually a lot of this is driven because now we have a very pointed tool that allows us to identify aortic stenosis, to very pointedly go and review those aortic stenosis, and then directly improve and work with our sonographers to be able to acquire their cases better. And if there are discrepancies between one study and a previous study where perhaps the quality of the acquisition is not as good as a previous study, we can now go and be much more specific and much more directed towards those patients. And the end result is an overall improvement in our ability to assess aortic stenosis. Cardiac intelligence has made us or allowed us to be more efficient in identifying patients with aortic stenosis and make certain that they get to their clinic appointment in a timely fashion. So in this control chart, we've taken patients with significant aortic stenosis and looked at the time that it takes from the index echocardiogram to get to the appropriate follow-up appointment. And we can see Mpirik cardiac intelligence went live in early 2020, and our process was very unstable. But in recent months, we've had a significant and sustained improvement in the amount of time that it takes for an index echo to ultimately lead to a follow-up appointment. And again, I'd like to focus on the fact that that has been sustained for quite some time. Where do we go from here? So we've started with structural heart and the aorta, but we're not going to stop there. Our next phases are the guideline-directed medical therapy to include heart failure, both preserved and reduced, looking into ischemic heart disease, hypertension. We're going to expand further into structural heart to include the stenotic lesions, mitral tricuspid regurgitation, pulmonary regurgitation, as well as into the electrophysiology space to include the risk of sudden cardiac arrest, AFib, and the risk of left atrial thrombus and potential left atrial occlusion. But we use a very research-first approach to validate the data. We like to make certain that whatever algorithms are run, they work, and also make certain that they are showing benefit before we expand to the institution more broadly.
Great information, very enlightening, and I want to thank our speakers for educating us on SCA, as well as the technology advances to improve the quality of care while addressing health equity in underserved populations. We did leave a few minutes for questions, and it looks like we've had a couple come in. So let's get started. Now, if we're not able to answer here, we will follow up with you individually.
All right. Hello, panel. And, we did have a few questions. We also, I think, had a few areas, too, that we wanted to elaborate on just a little bit, just through our conversations and our discussions with other folks. But yeah, maybe Dr. Booker, you want to take a shot at that question that we had come in through the chat?
Sure thing. So for anyone who might not be able to see, the question is 20% of clinicians felt that notifications impacted their decision to refer, and 66% surveyed would like to continue to receive notifications. Can you comment on why these rates may not have been higher? I think some of that may be due to bias and not necessarily a negative bias. Most of these echoes that are done with patients with significant valvular heart disease, or maybe not most, but a significant percentage, are actually ordered by cardiovascular providers. And so to receive that direction to say that, hey, your patient has significant valvular disease, you may want to refer them on, I think there was a feeling that, well, I understand how to refer those patients, and I would have done that already. As an institution, we elected to send these notifications out to all providers except those that are on the structural heart team, mostly from a overall quality and safety perspective, because occasionally, while we may do a very good job on the whole as cardiovascular providers referring those patients where they need to go, occasionally patients may slip through the cracks, and this is really a safety net for those patients that slip through the cracks. So there are those cardiovascular providers who understand the guidelines and understand how cardiovascular care should be performed, and when we did the survey, it was that group of people who felt like the service didn't necessarily meet their needs ideally. But again, we continue to implement this, and we continue to use this because it is not necessarily to drive the cardiovascular providers to understand what the guidelines should be, or to better understand what the approach should be, but really as a safety net for those occasional or those never events, as we like to call them, where the patient should never, if they need appropriate care, that we should never forget about them. So it really serves two purposes. It is to help guide therapy for the non-cardiovascular driven providers, but then to serve as a safety net for the cardiovascular driven providers. So I think that's probably why we didn't see those percentages, or at least the 66%, why we didn't see that number higher. It was a strategic choice made institutionally.
Good. Thanks for addressing that. I appreciate the elaboration on that. I know one area that we wanted to talk about, maybe, and Dr. Gupta, I think you're in a good position to address this. We certainly talked about the opportunities, but what we didn't really elaborate on is who do you need to engage at the health system to really get this program going? Are we talking physician champions? Obviously CV service line. Maybe could you just elaborate a bit on what that would entail? You might be on mute.
Over there.
There you go. Oh.
Sorry, could you repeat the question?
Oh, yeah, sorry about that. So we talked about the program, obviously, what it takes, and we were hoping you could elaborate just a little bit on, who are the key players in the healthcare system that you need to engage to initiate such a program?
Yeah, I think it's you have to kind of engage it at all levels. So I think from the electrophysiology space, we had to validate that we felt the workflow was appropriate and the patients being referred were the right patients, patients who would be good candidates. I think we also had to engage administration so they would see the value of integrating something like this as well too, and then as well as educating the general cardiologists who generally people are not fans of additional alerts, but if you tell them this is going to help kind of close a gap in care and help improve the care of the patients, I think and this is really just adjunctive to that. I think people really will buy into that. People have bought into that, and I think that's made it easier. I think the help in our institute in particular, we had made kind of a less robust version of this many years ago that didn't work very well. And so I think what's nice about the Mpirik experience is that it does add more functionality and greater accuracy, which I think people have really resonated with.
Great. And I know, Dr. Booker, we had kind of talked about maybe you could address where are you seeing most patients kind of fall through the cracks when it comes to some of these AI programs?
I'll address that, but I'd actually like to pair that with this next question that I see in the chat, and that's
Sure.
can you or have you determined the percentage of those identified as not receiving follow-up treatment plans that fall into categories of racial and/or ethnic disparities? And I think that these two questions actually flow really well together because we see that in the uninsured or underinsured. Also, certain socioeconomic and social determinants of health. There are certain groups of patients that tend to perhaps be less well plugged into the system and are less likely to receive certain care. And so we do see that. I can't necessarily give you exact percentages, although we do have some data that we're actually working on social determinants of health in various conditions, including aortic disease and mitral and tricuspid disease. But these are the patients that typically, or not typically, but are frequently falling through the cracks. And this is, again, serving as that safety net for them to help guide them where they need to go. And also to raise awareness to the providers that you have a patient that may be falling through the cracks and perhaps is missing an opportunity to receive care that could be appropriate for them. Another series of patients, in addition to those that are uninsured or underinsured, or those with certain social determinants of health that tend to fall through the cracks, we do get a lot of index echoes that are ordered by non-cardiovascular providers. And sometimes there is a lack of appreciation for which conditions should be referred on to higher levels of care. And so those providers or those patients that haven't made it in or don't have primary cardiologists also tend to slip through the cracks. So again, two very disparate groups of people, kind of the uninsured and underinsured, but then also those providers that aren't cared for by primary cardiologists or that has, at least in our experience, been the greatest opportunity for closing the gap.
Good. And Logan, I think there's a question for you in the chat. I don't know if you had a chance to look at that.
Yeah, absolutely.
Okay.
And that's a great question about the confidence. So our process of providing confidence to these physicians about our screenings is really showing them, at least on the specific hemodynamic, discrete measures of where patients would go in the flow of when an alert would go off. So for example, we'd work with Dr. Booker and show him, hey, this is a typical patient flow. As far as the natural language processing, that ontology library, we typically would talk at a high level and say, what are the sort of symptoms or the past medical history that you'd be looking for? And then we'll cover, with our past, the manual labeling aspect to help create that dictionary. And so we don't necessarily go through the NLP models, but the total patient flow, and we will address with the physicians. And at the onset of these engagements, we'll spend the first 3 or 4 weeks, and then we sit down with the physician. We go through real patients and say, hey, this is the one that was flagged for X disease. Does that meet, what you would have considered potentially undertreated patients? And if not, there's that configuration period. But overall, you're absolutely right in providing confidence for deep learning. We need to use these other ML and explainable models first and include the physicians in that whole process.
Cool. And, Logan, while we have you, I think we were hoping you could elaborate a bit on, what IT security and maybe how you're interfacing with EMR. That's certainly something that comes up, and maybe you could talk about that a little bit.
So there are really two main aspects to our success with IT. The first one is that we're going to be exceeding, or we're not going to be, we do exceed the minimum compliance requirements for healthcare software while being able to provide the results from our annual third-party audits. And then we also provide results from that. We do annual software penetration testing. And secondly, we can provide the other confidence through our other many successful implementations to date. Our partner hospitals are very willing to be referrals for us, both on the clinical and the IT front. And they tend to share their experiences and also the methodology for those implementations. So through our experience, we have interface specs, the works, and we can provide that confidence to get over those any potential IT barriers.
Great. And we had a question come in about removing providers from notification process. Who wants to maybe take that one?
I'll take it. Yes, it is possible to remove providers from the notification process. We have a multi-tiered notification system. Some notifications go to some providers versus others. As the medical conditions become more significant, we tend to remove fewer and fewer patients from the notification list, because as we start to approach more clinically significant disease, we feel that it's more important for overall patient care and less so much for provider convenience. So, for instance, we have the ability to notify for less significant aortic disease, or we may notify primary care providers for those and not notify cardiologists. But as we start to approach the disease where sudden death becomes a real issue, we are less likely to remove. So yes, it can be tailored depending upon the needs of the institution, depending upon the needs of the provider. You really just have to balance what you as an institution find to be most important, and then figure out the best way to achieve those goals.
Great. We are going to start wrapping up here soon. So if anyone in the audience has a question they want to get in, now would be the time. Otherwise, I think we'll kind of do one more each for everyone, just kind of wrap up a bit. Dr. Gupta, I know we had talked a little bit about this kind of the same day ICD implementations, and what's the potential there for patients for same day dismissals. Could you maybe just talk through that a little bit?
Sure. I think we've really implemented that, and we've had it for a couple of years. But we will offer patients the ability to go home the same day. We do most of our ICD implementations just under a moderate sedation, which has helped recovery since fibrillation threshold testing has kind of gone out of favor as routine practice, and so patients recover pretty quickly from the really functionally an ICD implant is really not much different than a pacemaker implant in terms of the procedure and the recovery from that standpoint. So a lot of our patients have been going home same day. What was interesting, obviously, how things changed during COVID is that patients who were offered the chance to go home pre-COVID were generally concerned and not feeling like they were ready to go home the same day. And once COVID came, they were thrilled to get out of the hospital the same day, and we've kind of pivoted just with that alone to the majority of our ICD implants go home the same day. I think the one category that we still watch them overnight are people who are pacemaker dependent, and we usually generally watch that category of patient overnight, but that's a relative minority, particularly in the ICD population.
Cool. And Dr. Booker, we hear about hospitals and how they're dedicating resources to improve health equity for the patients. Is the use of AI and Mpirik solution, is that helping with this endeavor?
It absolutely is. When it can become very expensive to have employees or to have people coming in and crawling through data and trying to identify patients who meet certain criteria, it is far faster and overall, what we found, far less expensive to have a machine go and review our data to help us identify these patients. It may not be quite as big a deal if you're doing 5,000 echoes a year, but if you're doing 30, 40, 50, 60,000 echoes in your system, or whatever your index procedure is going to be, it becomes a significant challenge. And interestingly, I know we're coming on time. There is an actual follow-up question that I think the rest of my answer will touch on, looking at follow-up requirements post-procedures, and can you set alerts for that? And I think, again, it really depends on what you do in the institution. I think the discussion that we're having today, we're talking about arrest patients and people who need ICDs. But the extent of what we actually look for is far broader than the discussion and far broader than what was presented here. We evaluate pre-procedure, post-procedure, multiple valve disease. We have a whole host of things. We actually have an entire quality improvement foundation built on this notification system and reviewing studies. So it really depends on just how creative you can be and how invested your team of providers and institutions are, and the willingness to customize and collaborate your institution and the vendor is really only limited by your imagination.
And then just to tack on to that, for that specific question on follow-ups, we do get on the technical side, we get a continuous stream of data. So we are constantly able to assess that patient at each event that comes through the medical record. Excellent.
And let's end it, Logan. How about how does an EMR patient query for patient information, how does that engage with the Mpirik solution?
Yeah, absolutely. It's a great question. Always comes up. And so it's really all about data availability. EHRs are composed of a lot of unstructured data that's not accessible through these traditional data queries. So it really requires a conversion from unstructured data to structured data. That's really what sets us apart, is our ability to label this data and put it into a format that can be queried accurately. So at one of our sites, we decided to go head-to-head versus another Epic query that was trying to identify patients. And we were consistently able to identify more patients that would be appropriate for referral because of our access to this data, or the free text of the reports and the clinician notes. And we often find that it's more than just the discrete hemodynamics that will identify a patient for this. So the ability to process that unstructured clinical data provides us the accuracy needed to give that confidence in our screens to the referring community. It's more than just identifying that potential disease as well. So we're going to go the extra mile and assess the data for appropriate care plans, and that way that these patients can then receive the right care at the right time.
That's great. Great. Well, listen, I really do appreciate everyone coming on today. I know your schedules are hectic, and sharing your knowledge and about the advancement of this really interesting program, and it can, I think, benefit a lot of organizations out there. Thank you to the audience for spending some time with us today. This will be available on demand, or at least aspects of it, in the future. So we will follow up with everyone who registered to share that information so you can view or share with your colleagues. And we'll keep you apprised. This is a evolving approach solution. I would think you guys are learning a lot, weekly basis. And our goal here is to keep you guys informed of how the progress there and how others are benefiting. If you have any specific questions, please follow up with the individuals that we've listed on the screen. And thank you again for joining us. Have a good day.
Thank you.
Thank you, everyone.